Hello, and welcome to the UW Medicine Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Saramelli. I oversee the Grand Round Series for our department. Back in October 2020, we shifted our Grand Round Series to a webinar format, and we've had presentations covering many domains. And I wanted to reemphasize a point today about completing a Grand Rounds evaluation form. That's a very helpful for me to see comments about the presentation and to help shape our Grand Round series over time. I want to stop there for now and get quickly to Dr. Unitzer, who will introduce today's speaker.
Okay, well, thank you, Joe, and welcome to all of you for our Grand Rounds presentation today. Today, we have a wonderful opportunity to hear from our colleagues, from our colleague, Dr. Pamela Collins. Dr. Collins is a psychiatrist who joined us at the University of Washington a few years ago to develop and lead a program in global mental health that is jointly sponsored by our department and by the Department of Global Health. And Pamela has done just an amazing job, really, developing this program here at UW over the past few years, working with students and faculty and staff across our two departments, across the entire UW campus, and really across the globe. I had recently had an opportunity to take a look at all of the places around the globe that Dr. Collins has traveled in the context of her work since coming to UW, and it was really amazing. I mean, there are places I'd never even heard of before. And I'm so pleased with all of the amazing work that Pamela has done since she's taken on this leadership role in global mental health. And she's also taken on more recently another leadership role for another major program, a related program here at UW, the ITech program. And I suspect she'll tell you a little bit about that as well. Many of you have had a chance to meet and work with Dr. Collins, and the rest of you are in for a real treat today as she gives us an update on global mental health and some of her work in this area. So let me stop and give a big welcome and thanks to Dr. Collins.
Thank you so much. And I am going to share my screen so that we can get started. Okay. Thank you. Thanks for the introduction. It's a pleasure to be here today. I want to start with a story. In March of 2020, my University of Washington colleagues, Shannon Dorsey and Tessa Concepcion, and I were preparing to meet our Nairobi colleagues to launch the largest and final phase of our study, which was focused on competency-based training and psychological interventions for community-based health volunteers in Nairobi. And these community health volunteers would be trained to address trauma symptoms among children and adolescents in a Nairobi district. COVID-19 stopped us in our tracks. We didn't get on the plane, we didn't go. And over the subsequent weeks and months, we thought about how best to address the issues that we were supposed to do when we got on the plane and what could we do. So our team pivoted as Nairobi launched its own quarantine measures, and pretty much everything around the world came to a stop. And there, as well as here and in so many places, people began to experience the emotional challenges of COVID-19. So working closely with our colleagues in the health system in Nairobi, we were able to transform our training to a digital format with a focus on psychosocial support. And the community health volunteers and teenagers connected over cell phones. This fresh, new support team met youth with severe depression, with suicidal ideation, teenage mothers in need of emotional and material support, young people looking for a private space apart from their parents' eyes and their ears to share some of their struggles. And the needs were tremendous. Our team recognized that they were scratching the surface of a tremendous number of unmet needs. And we would expect the same. We've discovered the same thing in the United States during COVID. We know that this area of mental health is full of unmet needs, and we shouldn't be surprised. The latest iteration of the Global Burden of Disease Study 2019 tells us that 970 million people live with mental disorders globally. That's 13% of the global population. 161 million live with a substance use disorder, and these as a group are the leading causes of disability around the world. This is a global issue, and I remind you that global in global health refers to the scope of the problems, not their location. So it requires all of our brains thinking together globally for local responses. So these conditions are prevalent around the world. And in 1990, the Global Burden of Disease Study highlighted for the first time, that was almost 30 years ago, that the magnitude of healthy years of life lost due to mental and substance use disorders. And we know that those health system responses are inadequate, and often self-care and community responses cannot meet the needs of people. The challenge was that in 1990, things were quite different, right? In the face of high rates of maternal mortality, infant and child mortality, a growing AIDS epidemic, the data on depression was a rallying cry to the mental health community, but was anyone else really listening? Not so much. In fact, at that time, as you can see from this graph, that non-communicable diseases accounted for less than half of the global disease burden. At the same time in 1990, what was really present and fresh on people's minds was the AIDS epidemic. The AIDS epidemic saw its steepest rise in new infections, in deaths due to AIDS, and in the prevalence during those early years of the 1990s before treatment was available. And the response to the epidemic was powerful. People were dying, and activists risked everything. This was in those years before treatment was available, and they were successful. The response to the epidemic was powerful. They stimulated new research, and treatment actually became available to many people. I want to remind you, though, that no part of the world was untouched by the AIDS epidemic. And today, an estimated 38 million people now live with HIV. And I emphasize live because HIV has become a chronic disease. A decade ago, Kevin DeCock wrote that HIV prevention and treatment scale-up during the first decade of the 21st century qualifies as a game changer that has irreversibly changed perceptions of and approaches to global health. And I want us to think about that in the context not only of HIV, but of mental health. So what happened in HIV? Research and innovation and more. The AIDS community saw the rapid development and scale up of innovations, rapid HIV tests, early infant diagnostic tests. They saw a willingness to change when new evidence appeared. They were able to incorporate new activities into long-standing programs. Quick and coordinated changing of antiretroviral drug regimens happened. And importantly, there was targeted funding, which meant that there were partnerships between governments, multilateral organizations, community-based organizations, civil society. All of these came together. And the demonstration that treatments could work and could save lives stimulated an enormous investment of donor funding. And this required people to bring their skills, bring their knowledge to bear in the work of implementing. And people here at the University of Washington responded to that call. And among those people were the folks who founded the International Training and Education Center for Health, or ITEC. This is currently the largest center in the Department of Global Health. It was founded by Ann Downer and King Holmes, who are now emeritus faculty members of the Department of Global Health, with colleagues at the University of California, San Francisco. The mission was to work with partners to develop skilled healthcare workers and strong national health systems in resource-limited countries. And that remains ITEC's mission. And to do this, ITEC promotes local ownership to sustain effective health systems. I had the privilege of joining ITEC as its executive director in July of 2020. And it's an incredible network. We currently operate in 17 countries around the world, and that number grows. We have more than 1,000 staff, consultants, and clinical faculty and contractors in Eastern Europe and Sub-Saharan Africa, and other activities in the Caribbean and South Asia as well. Since its inception, ITEC has led or supported programs in more than 30 countries in Sub-Saharan Africa, South America, Asia, Eastern Europe, and the Caribbean. And a lot of this work was really focused on supporting the implementation of AIDS care and treatment programs beginning. ITEC's work emphasizes capacity development activities, including developing and adopting national level policies and guidelines, fostering leadership and management skills, strengthening workforce development, creating and implementing continuous quality improvement approaches, and developing clinical mentoring and supportive supervision standards. I think another really important value that ITEC has and has had all along is that once these products are developed, how do you transition them to ministries of health so that they are sustainable and enduring? And to date, ITEC has transitioned more than 350 programs to local entities and launched indigenous health organizations that have received up to $32 million in funding. But we'll come back to that. ITEC has a partnership model that emphasizing identifying needs, structuring partnerships, securing the technical resources needed to do the work, providing technical assistance, monitoring the performance, and then, as I mentioned, transitioning that project so that national systems can take it on and sustain the work. Activities, many of ITEC's activities support controlling the AIDS epidemic. And for those of you who may not be as familiar with the way that UNAIDS and PEPFAR, or the President's Emergency Plan for AIDS Relief, which is the US government funding that supports a lot of implementation of HIV care and treatment and preventive activities in countries around the world, the current goal is to not just control the AIDS epidemic, but to end the AIDS epidemic. And that means having 95% of people know their diagnosis. And of those that test positive, 95% of them should be linked to treatment. And of those that are linked to treatment, 95 of those should have adequate adherence to their care so that they have viral suppression. That means that there's no detectable HIV in their blood when it's tested. And ITEC supports this work through both direct service, often contracting with healthcare providers, clinicians to deliver these services, but also through technical assistance support, working closely with national policymakers and ministers of health, strategic information, digital health, to ensure that we meet these targets. We help to meet these targets. I'll give you a few examples of what that looks like. For HIV care and treatment, ITEC Zimbabwe, which is now Zimtech, works with local partners to manage, HIV treatment delivery, so delivery of antiretroviral drugs, community adolescent treatment teams, home visits. And Zimtech has supported HIV testing for more than 3.5 million people and the initiation of more than 180,000 clients on antiretroviral therapy. The other side of treatment, the step before that, is prevention. And VMMC stands for Voluntary Medical Male Circumcision. ITEC is implementing this in Zimbabwe and has been doing so for 8 years, and cumulatively has been able to provide male circumcisions to more than 300,000 men, averting approximately 32,000 cases of HIV infection. And that's based on modeling that the Gates Foundation has developed around voluntary medical male circumcision. ITEC has also worked closely with electronic medical records. This is an example in Haiti, where ITEC began to develop the electronic medical record system, eSante, which is integrated with open source laboratory information systems, OpenELIS, and this work continues now. In Cambodia, ITEC has been supporting laboratory management through mentoring new lab technicians and helping to train people in mentoring skills and laboratory quality management practices. We've also moved into non-communicable diseases. I think this is an awareness that PEPFAR and the global AIDS community has, that there are co-occurring conditions with HIV, and many of these are non-communicable. Cervical cancer is one of those. ITEC launched a national campaign in Namibia to raise awareness of the importance of screening for and treatment of cervical precancer in women. And this has been really critical during the COVID-19 pandemic. They've managed to perform more than 14,000 screenings and 1,700 treatment procedures for HIV-positive women. And finally, we've also been ensuring that we address the needs of vulnerable populations. ITEC is working with Caribbean populations, key populations. Those are people who are at increased risk for HIV, including sex workers, transgender people, and men who have sex with men. So we have a clinical preceptor program that builds on clinicians' capacity. It increases clinicians' capacity to provide non-judgmental, high-quality, comprehensive HIV care to the most at-risk communities. So ITEC provides a really rich platform for implementing programs, but also for layering research on real-world implementation. So this is just a snapshot of what we're doing in the center, but you can see what can happen when evidence, political will, and investment coalesce around a health problem. Can we see the analogous trajectory in our field? Specifically, how are we at UW working to make this happen? So I'm going to go back to our story about early in the AIDS epidemic. Early in the epidemic, a small number of researchers and clinicians recognized and really began to draw links between HIV and mental health, both in the United States as well as in other countries. I think first recognizing that people living with HIV had elevated rates of depression, anxiety, PTSD, substance use problems, and that this needed to be addressed. But another issue that became apparent, primarily probably to clinicians first, was that people with severe mental illnesses were at increased risk of infection, and that was often linked to a history of homelessness, to the experience of sexual violence, early sexual debut, drug or alcohol use during sex, and lifetime illicit drug use, as well as psychiatric symptoms that could impair judgment or impair cognitive ability, and often make people more vulnerable in that context. So what we know about HIV prevalence in the United States is that in the general population, HIV prevalence is around 0.3%. But among people with serious mental illness, that prevalence ranges from 2 to 6%, which is a 4 to 10-fold difference. And this isn't only true in the US, this is a phenomenon that's true in many places. In Uganda, the HIV prevalence in women with severe mental illness is around 14%, and among women in the general population, around 8.3%. A fairly recent review in The Lancet also showed what this looks like in countries around the world, that we see the elevated prevalence in North America that I mentioned. In Europe, the prevalence of HIV among people with SMI is also higher than the general population at around 2%. And studies in sub-Saharan Africa have shown a prevalence of around 19% for people living with severe mental illness, almost 3% in Central and South America, and 1.5% in Asia. So you can see a significant effect of the epidemic on this population, but often little attention. So this has been one avenue through which mental health has also crept into the global health agenda. people began to use the funding that was focused on HIV to say, hey, we need to address these vulnerable populations related to the epidemic, and specifically who have mental health problems. And of course, as the epidemic has continued, we recognize that actually having a co-occurring mental health problem, a lot of the work has been done on depression, since that's most prevalent, has adverse effects for morbidity and mortality. And this is data from the US from Brian Pence's study showing that for every 25% increase in the number of days you live with depression, there's a 19% increase in mortality for people living with HIV. There's actually really recent data that's come out showing a link between depression and viral load, that actually for women, there's almost a twofold increase in viral load for women who have depression compared to those who do not. And that data is coming out of Tanzania. So equally important as data, there's been ongoing advocacy over the last 30 years plus, calling out the need to redress the disparities in mental health care between and within countries, starting with the 1995 World Mental Health Report, the 2001 WHO World Health Report, which emphasized integration of mental health into primary care. The 2007 Lancet series on global mental health really brought attention, and its call to action said, you know, we need to do something as a mental health community, specifically around action for mental health in low and middle income countries where there's a real dearth of care and a real dearth of access to treatment. The Grand Challenges in Global Mental Health, which I helped to lead at NIMH, laid out the research priorities that we needed to accomplish to enable to change in the next decade the burden of disease. Well, that decade is up, and we need to think about where we are now and what more can we do to keep moving, making progress around mental health. And finally, the World Health Organization's Mental Health Action Plan, which was recently extended to 2030, laid out very clear targets that align with the Sustainable Development Goals, which has its own mental health targets. And I think an important document for our field, as many of you are aware of, is the Lancet Commission on Global Health and Sustainable Development, which has taken a look at where we've gone in this field, where we've made progress, and where the problems are, and emphasizes that one way to approach mental health going forward is to say, how does it link to other areas? How does it link to other areas of health, which we'll talk about today, but also how do we ensure that people understand that mental health is critical for global development? And this has been a helpful advocacy call. The other good news is that UW has responded to this call. Jürgen mentioned that I came in 2018. I had the pleasure of joining the UW to lead the Global Mental Health Program, where many of our faculty have already been, and we're already leading impactful research and research capacity building in global mental health. And this is a glance at some of the core members of the faculty in global mental health. And over the past couple of years, we've taken the time to strategize specifically around how we will contribute to the global effort to support mental health and care for people with mental health problems. We've engaged a global external advisory board so that we could receive honest and critical input from leaders in the Seattle area, the United States, Latin America, Asia, Africa, and Europe, as well as people with deep experience in multilateral organizations. And you can see the folks at our first EAB meeting a couple of years ago. And what's been helpful for us is that we have coalesced to identify what can our role be in this global effort. And our role is to develop, test, and build the capacity to deliver contextually appropriate and sustainable models for mental health interventions with local and global partners. So how do we do this? So what you're looking at here are, on the left, the drivers are strategic priorities, and on the right-hand side, where we hope to go. And I'm going to see if I can actually move the video without losing the slide. So we want to understand mental health intervention gaps and opportunities in diverse communities. And in order to do that, we want to develop products to better understand those gaps and opportunities and to reduce gaps in treatment, quality, and prevention in lower resource settings, locally and globally. We want to build workforce capacity to deliver mental health services. And by doing that, we'd like to achieve a sustained increase in the number of people who are capable of delivering minimally effective mental health services. And third, we'd like to elevate mental health on the global and local agenda. And to do that, we need to increase engagement, funding, and support for mental health services and interventions, both treatment and prevention. And I'd like to show you what some of our work looks like in these pillars and along with our priorities. So our strategic activities begin with a focus on these groups, these populations: women in the peripartum period, children and adolescents, refugees and immigrants, and the emerging priorities, those with the asterisks, are the places where we want to go, working with people with severe mental illnesses. The interventions that we, I think, are most facile with have to do with integrated care and, of course, collaborative care, working with our partners to see how this can be brought to bear in the environments where they work and where they are trying to figure out how to bring mental health care into different platforms. And finally, with respect to diagnoses, a lot of our work focuses on common mental disorders, and we are moving toward more activities around severe mental illness and substance use disorders as well. And we invite you to help us develop those emerging areas further. So I'm going to talk about each of our pillars and give you some examples of the work we're doing in these areas and come back to this question of how do we ensure that we are making an impact and moving this agenda globally and locally. So with respect to understanding gaps and opportunities in diverse contexts, we were really fortunate to win a contract to work with the World Health Organization to help launch their special initiative from 2019 to 2023 on mental health. The goal of that initiative is that by 2023, universal health coverage would ensure access to quality and affordable care for mental health conditions in 12 priority countries to 100 million more people. Our team conducted the situational analysis for the first 6 countries. We did that in the early part of 2020 before the COVID lockdown occurred. Supporting work with colleagues in Bangladesh, Jordan, Ukraine, Zimbabwe, the Philippines, and Paraguay. These represented one country for each of the WHO regions. We adapted the PRIME tool. PRIME stands for the Program for Improving Mental Health Care. We adapted their situation analysis tool and worked with our counterparts in these 6 countries to both do desk reviews, look at secondary data, and the teams there conducted interviews in facilities and with key informants in their sites. So this approach, really understanding in a rapid way, how do we get a sense of what countries are looking for, help to move the special initiative to its next phase. Another one of the projects that we've been focused on around this issue of understanding gaps is the Urban Adolescent Delphi project. For those of you who may not be familiar with the Delphi methodology, this is a methodology for building consensus. It engages experts and goes through several iterations to come to consensus around a key question. We are working with partners at the University of Washington, the Population Health Initiative, Urban at UW, and external partners, Cities Rise and the University of Melbourne, to ask what are the critical factors for young people living in cities that can support their mental health, or what is it that cities can do to create mental health friendly cities for young people. At present, we've engaged people from more than 50 countries, young people and older people, to identify these priorities. And we're in the process of analyzing them to really think about how they can inform policymakers as well as researchers in order to improve access to care, as well as sustain mental health and promote mental health in these environments. This is just a picture of the word cloud that's emerged from some of the responses in this Delphi. So our second pillar, building workforce capacity. We have a lot of work in this, and much of our work, in fact, falls into this category. And it requires understanding health systems and community resources to identify and develop new cadres of mental health care providers, often through task shifting. Shannon Dorsey has been leading the work that you see on this screen with her colleagues in East Africa, focusing on children and adolescents, and showing that task-shifted delivery of an evidence-based treatment, in this case, trauma-focused cognitive behavioral therapy, is effective in community settings. In 2019, we were awarded funding from the World Health Organization to join their EQUIP platform. EQUIP stands for Ensuring Quality and Psychological Support. And the focus of EQUIP was to develop a WHO workforce package for mental health and psychosocial support. Again, here, recognizing that when you're trying to train a diverse cadre of providers, you need to really think about quality. And one way of ensuring quality is to ensure the competency of these providers through carefully designed competency-based training. So we have a wonderful partnership in Nairobi that leverages Shannon's experience in Western Kenya, the University of Washington's 30-year experience in collaborations with the University of Nairobi, our collaboration with Cities Rise and with WHO and George Washington University to focus on workforce capacity building for youth. And I started out this talk with the story of our training and efforts in this. You can see an image here of the first training that we did when it was nice and sunny and people could still hold hands, and the community in Nairobi that we're working in called Mukuru to help develop this work and move it forward. Ian Bennett and Amrita Bhatt are working in Vietnam. I've been a part of that team as well. Also on work that focuses on the health workforce, but is developing the health workforce through collaborative care in southern Vietnam. And this is supported by NIMH and the Fogarty International Center. So it's formative work to adapt collaborative care model to integrate mental health into community-based perinatal mental health services in Kanta. This work builds on 8 years of relationship that began with Richard Vieth and is established with Kanta University of Medicine and Pharmacy. I think that group just had one of its first conferences with NIH just recently, able to share their progress. Brad Wagoner is leading work in Mozambique, again, focusing on this pillar of developing the workforce. Brad works with Health Alliance International, utilizing the systems analysis and improvement approach. And this is a multi-step evidence-based implementation strategy that's used by managers and health provider teams to systematically identify and address bottlenecks in their own healthcare delivery systems and helps people prioritize the solutions. So Brad and his colleagues are applying this to the treatment cascade for people with severe mental illness in Mozambique. And Brad recently had an R01 that's expanding this work in Mozambique as well. Keeping on the theme of severe mental illness, Dror Ben-Zev is also diversifying the kinds of providers that Global Mental Health works with. Dror leads the mHealer project, which applies user-centered design to collaborate with the leaders of prayer camps and faith-based healing centers in West Africa, where many people seek mental health care and support. And the goal of this project is to create psychosocial support tools for these providers as they manage people with SMI, with the goal of providing information about psychiatric illness, actual tools to manage care humanely, and to ensure that we protect the human rights of people that are receiving care. Lori Zollner's team is working with communities in the Seattle area and overseas. Lori and her colleagues have developed the Islamic trauma healing approach to addressing trauma symptoms for communities affected by post-traumatic stress. They are working specifically with the Somali community in this area, as well as Somali communities in Somaliland, to test this intervention, which is rooted in evidence-based approaches to trauma care, but has been culturally adapted. It is incredibly culturally sensitive, and uses lay health workers, lay people who are not health workers, but lay people to guide and provide the needs of the community. Our team's work has also examined how we support the integration of mental health and non-communicable disease care. Lydia Twasiak and Deepa Rao are investigators with the Independent Study, which is a study of a collaborative care model on depressive symptoms, hemoglobin A1C, blood pressure, cholesterol among people with diabetes and depression. They recently published their 24-month outcomes, and this is a trial that showed the effectiveness of the collaborative care model in diverse treatment settings in India, specifically for the reduction of depressive symptoms. And I know that they're, I think, still looking at their 36-month follow-up data as well. So I want to come full circle back to HIV and mental health and back to ITEC. Deepa Rao with ITEC South Africa and Inga Peterson and her colleagues at the University of KwaZulu-Natal led the Mental Health Integration Program. This was a CDC-funded program which applied the collaborative care model to integration of mental health into primary care, which in South Africa is where people living with HIV receive services. This implementation project was conducted in KwaZulu-Natal and in Mpumalanga provinces, and I think is a wonderful example of what I think is a beautiful opportunity. Was then they were able to receive funding from NIMH for one of the NIMH hubs to build the science of implementation on top of the work of implementation. So the Southern African Research Consortium for Mental Health Integration, of which Deepa is one of the multi-PIs along with Inga and Arvin, our colleagues in South Africa, have been able to conduct implementation research, also build research capacity among the consortium of participating countries. In addition to South Africa, those include Mozambique and Tanzania. And this has also been an opportunity for some of our newer global mental health faculty. Christopher Kemp, who's one of those newer members of our faculty, contributed to this research through his doctoral research. And they've been able to really dive down to understand what are some of the factors that influence the success of integrating something like depression screening into a primary care, busy primary care clinic in South Africa. And another example of integrating some of the mental health, both implementation work into the ITEC platform that brings opportunities for research, is this project integrating CETA, the Common Elements Treatment Approach, in Mozambique. So this was a collaboration with ITEC Mozambique and with Health Alliance International, which pilot tested the integration of the Common Elements Treatment Approach. And Shannon Dorsey is one of the co-developers of this intervention. And PEPFAR funded this, gave them money for a pilot study, which had really promising findings, as you can see, that 4 sessions of CETA in this pilot trial, this was a really operational research, 4 sessions of CETA led to a 50% reduction in mental health symptoms and 100% reduction in suicidal ideation. At 1 month, there was a 9% greater retention in care. At 3 months, they saw 19% higher retention in care. And the good news is that PEPFAR is interested in seeing this approach scaled up across the country. and this team is currently working to see how that can happen across Mozambique. Our final pillar is about elevating mental health on the global and local agenda. How do we use the evidence base to increase access to care for people who need and want mental health services? We're doing this through collaborations with multilateral organizations. We supported UNAIDS in developing the background document for its first ever program coordinating board, thematic focus on integration of HIV and mental health care. And excitingly, the outcome of this stimulated countries to push for UNAIDS to develop guidance on mental health integration. And this is one of the projects that I continue to focus on. We've also learned that collaborating with non-researchers, but other kinds of organizations that are out promoting the word, getting the word out, advocating for mental health can be useful as well. We work closely with United for Global Mental Health to help synthesize our evidence and disseminate it at critical junctures. This is a commentary that briefly describes why mental health integration is important for both ending the HIV and TB epidemics and how the Global Fund can help to integrate it. We're also excited about a new NIMH Center grant focused on HIV and mental health that UW will soon be awarded. Jane Simoni is the principal investigator of that award. And among those of us in psychiatry, Deepa Rao and Lydia Trastiak and I will be co-leads on various cores of the center. And I think this will provide us some of the infrastructure to continue and to expand this important work that keeps mental health on the agenda and also shows in a broader sense the global health community where it's important to increase good outcomes for not just mental health and mental disorders, but also good outcomes for other conditions. So we know that this is the time to invest in mental health care. Non-communicable diseases are increasing at a rapid rate. You can see that, in fact, there is a rate of decrease of communicable, maternal, neonatal, and nutritional diseases has accelerated since 1990 and that first global burden of disease study. On the right-hand side of this graph, you can see that the rate of non-communicable disease burden has accelerated, and that includes substance use disorders and mental disorders. So it's important. This is where the attention needs to be right now in the world. We have to keep paying attention to infectious diseases, of course, because those are important, as you can see from this graph, which shows that back in 1990, when I showed you the original image, that fewer than half of the DALYs, or the disability adjusted life years, around the world were due to non-communicable diseases. Now we're at 64%. So a majority of healthy years lost around the world are attributable to non-communicable diseases. But you can see that this is not true to the same degree in every place. So our work is to continue to support and promote the work to reduce the burden of mental disorders, to promote mental health, to prevent mental disorders, and at the same time to show how this links to the communicable disorders that are continuing and will continue. And COVID-19 has certainly made it clear that these kinds of problems are not going anywhere soon. I want to end with thinking about how we do this work in global health. Here in the United States, the incredible police violence that we saw and have seen for many years, but on which a real floodlight was shown during the pandemic. Police violence that disproportionately affects Black people and disproportionately affects other people of color has also made us and forced us to think about what racism means in the context of global health. Global health is fundamentally about equity. And this particular era, I think, requires that we take a serious look at what it takes to build our vision of global health, equitable access to healthcare, and beyond that, to healthy lives sustained in healthy communities. And it means addressing these social problems that stand in the way of life, as well as healthy life for people. Deepa Rao and I wrote the call to action this year for the World Federation of Mental Health as it kicked off World Mental Health Day, making it clear that the current conversation we're having about racism in the United States has individual consequences, but it also has consequences for how we work internationally. And the global mental health community, as well as the larger global health community, must respond. What we suggested is that this community needs to recognize and respond to racism in all its forms as a threat to health and well-being across the lifespan. We need to stimulate and accelerate efforts to achieve the Sustainable Development Goals, because those targets actually include targets to reduce inequality, to reduce discrimination, to reduce both racial and gender-based discrimination, among other things. And we have to invest in the social interventions that can enable these kinds of changes, alongside the behavioral interventions that address mental health specifically. We need to ensure access to quality and affordable mental health care and primary care. And we have to keep working to reduce disparities in mental health care, both in our own environment locally, as well as collaborating with our colleagues globally. I'm really delighted that ITEC and UW Global Mental Health are programs that prioritize these questions. ITEC is supporting the transition of country offices that have traditionally been part of the University of Washington into independent entities. This increases the likelihood that these organizations will be able to continue their work, because they will be able to continue to receive funding to carry out their programs. And it means decreasing the funding that the University of Washington receives, and obviously decreasing the power that's inherent in being the recipient of donor funds. And it's the right thing to do. I think all of our fields are questioning right now: global health, large, global mental health, our health community in the United States are questioning what power means and how do we have to share power in order to make a difference for the health and well-being of communities. We're asking questions like, who makes decisions? Who decides how to allocate resources? Who has the power to make these decisions? Who gives them that power? Who backs up that power? And how are we willing to share that power? As we wrestle with these questions in the context of meeting health needs here and with our colleagues around the world, I hope you'll join us. Thank you. I just want to acknowledge the ITEC faculty and staff who provided wonderful input to this presentation, as well as the UW Global Mental Health faculty and staff. So thanks a lot.
Thank you, Dr. Collins. So I encourage those with questions, comments to write into the chat or the Q&A, and I can help to go through those. One question came in immediately, Dr. Collins, and before getting to that, I think hearing, I mean, what a number of projects and individuals, large teams working on clinical trials, working on policy work, or just a range of sustained effort. And it's very motivating, interesting, noteworthy to hear about. Thank you for presenting today. One immediate question about ITEC. What role will ITEC have going forward? And this is me speculating on trying to clarify, but perhaps as other countries develop their own sort of ITEC form, BTEC, CTEC, as you show. Yeah.
Yeah, so we're a network. We have some of our ITEC has a number of country offices in its traditional model, and is also working with the new independent entities as part of the ITEC network. I was actually just on a call this morning with the executive directors of the ITEC country independent offices, which we've all decided that we can call ourselves PTECs as partner techs. And and I think everyone recognizes that partnership and collaboration is really important. And I think people recognize that they want to think strategically about how to develop their own organizations. But this history of collaborating is a long history. And I think importantly, because of the values of collaboration that ITEC has had over many, many years, these organizations would like to continue those partnerships and continue those collaborations. And we have projects together, obviously. So that work together continues. And we'll learn about, as we think about partnership models going forward, I think we'll all have a lot to learn.
Well, let's see. Another question has come in. And can you, okay. Two at the same time. For Ian Bennett. Okay, thank you for the great inspiring talk. A term that is often used outside of the US domestic context related to power differentials is colonialism. Could you help frame that term? Perspective is the same or different from our experience with the history of slavery in the United States?
That's a great question, and a great big question, Ian. I think colonialism, that term, forces us to do wherever we are is to think about whose voices have been dominant in every context, to think about where the power has been concentrated in every context, and certainly where there was European colonialism, we see similar patterns and similar trajectories for countries. The United States, of course, even after it was independent, decided to become a country that enslaved human beings, which I think takes that question to a whole other level, right? But when we think about colonialism, again, I want to come back to thinking about power. I think the other interesting aspect of this is that ITEC is actually doing a really nice series of podcasts around diversity, equity, and inclusion, as well as a book club. And one of the podcasts we were listening to an African researcher reflect on the term colonialism and reflect on the term post-colonial, also recognizing that, he said, from his perspective, he doesn't really think of his life in terms of pre-colonial and post-colonial, that in itself is a colonial perspective, because that's not necessarily the dominant theme, but the effects of people who have come from the outside to seize power, to keep power, and to keep others out of conditions that enable them to govern themselves, I think is similar. And we see that obviously racism is even a more extreme example of that in the United States.
Thank you, Dr. Collins. Another question regarding building capacity to sustain the work. It was more of a comment on it's great to hear about building capacity, but I wonder if you might expand on that. Is that the intent of each project? Is there a capacity building phase, for example? Are interventions tested? And is it thought that the next step would be determining how to get that intervention into action, for example? Can you tell us?
Yeah, thanks for that. Thanks for that, Joe. I think I sort of artificially classified a lot of the work that people are doing under that second pillar around building workforce capacity, because that is one of the byproducts of much of this work that we do collaboratively. But most of those examples that I gave are trials that are testing interventions, that are testing models of healthcare delivery with the goal of scaling those up. I think ITEC is a great example of a center that actually, this is what ITEC does. It actually takes interventions and it scales it. It helps bring them to scale in countries, and it helps to support training and capacity building in countries as they do that. In global mental health, since a lot of our work, except for where you saw the intersection with ITEC's implementation work, is research. So we're building the evidence base for how this can be done, and building the evidence base. And at the same time, I think ensuring that there is capacity on the ground that comes apart as part of the research. because I've been working closely with Shannon and her work in Kenya, I think that's a wonderful example where there are wonderfully skilled therapists in Western Kenya who have experienced a lot of this capacity building over the years because of this engagement. So the answer is yes, capacity building should be a part of all that we do, but that's not the end of it. I think that the goal is to figure out how these interventions can go to scale in ways that our partners want them to in their settings.
Thank you. And if I think I'm understanding capacity building correctly to mean that it's getting services out and figuring out a way to keep the services going, and a system to educate others to do it. Is that right?
Thank you, Joe. That's a great question, because capacity building can mean a lot of things, right? So in some cases, we're talking about very specific kinds of skills building. So how do you sit face to face with a community health volunteer and actually teach them how to do an interview with a patient or a client who has a mental health problem, right? So that's a real concrete kind of skills building. On the other hand, in ITech, some of the capacity building means many things, right? Some of it is mentoring clinicians, or having a warm line where clinicians can call in because they have a difficult patient or they have a complex patient and they need to talk to a clinical expert in that country, right? Or it can also mean using ECHO to provide on a regular basis training, remote training from Seattle to, let's say, in the Caribbean, where we do this, to support clinicians that are managing HIV care, that are also managing mental health care in the context of HIV care. So yes, and it can also mean helping ministries to who issue guidelines, then to be able to operationalize those guidelines and prepare the health workers to actually deliver services according to guidelines. Okay. So it's a broad term.
Thank you. And I was struck by capacity building a lot of times, or mental health, at least mental health services, assessment and treatment, finding a way through specialty or general medical clinics. It's a lot, consistent with work that many of us have done in CL psychiatry and primary care.
Yeah, I think, when we talk about task shifting and global health, often people are thinking about, oh, this means, training a lay health worker or training a community health volunteer, but task shifting also includes training a primary care doctor, right, on how to manage mental health care. A lot of these, it's a broad term that, yes, many people, especially in this department, are really accustomed to this kind of capacity building and coaching as well.
30 seconds, and just given the range of individuals participating in grand rounds, from trainees up, do you consider, are you a global health physician? How does one do the work you do? Is it a subspecialty? Can you comment on that?
Wow, I'm not sure how I would label myself. I do think of myself as, I think of myself as an unusual psychiatrist. And I think maybe my interest is in how do we think about, as a psychiatrist for communities and countries, how do we think about population mental health and what we can do on a larger scale. And I think the other part of and I think of myself as a collaborative psychiatrist, meaning, and maybe this is a new definition of collaborative care, which means that the only way you can do this work is with lots and lots of partners. This work takes teams, it takes collaboration, cooperation, it takes people really being able to sensitively listen to and understand what stakeholders need and what stakeholders want.
So perhaps many routes to global health.
There are many routes to global health. And I think the other takeaway that I'd like to leave people is that ITech is an amazing platform. We're interested in collaborations. We want to strengthen the collaborations between psychiatry and ITech, as well as across the campus. So look us up. I only gave you a tiny example of what's happening in global mental health and in ITech. So You know lots of names now from this presentation, and you can reach out.
Well, thank you, Dr. Collins, for going through the comments and questions. And we're at 1 o'clock. I do want to stop. A couple of comments came in that I will record, Dr. Collins. They're comments on thank you so much, and on the quality of the presentation. And thank you to our participants. And we'll end for now. And Mike, if you give me a minute just to record these comments, please.
Thanks a lot.
Okay, thank you.
Bye-bye.